India is a huge country and it has a lot of diabetic patients. And these diabetic patients are very prone to develop peripheral arterial diseases, either in the carotid, aorta, or the lower limbs. And now added to that, people who smoke and atherosclerosis are the leading causes for peripheral arterial disease. Now we are discussing about a patient who came to us with severe claudication and breast pain, and there is non-healing ulcer on the right foot and the left dorsal of the foot. We need a CT angiogram for the patient, and CT peripheral angiogram demonstrated there is an aorto bi-illiac occlusion. Now technically speaking, this aorto bi-illiac occlusion, whenever we see, so sometimes it's very difficult, whether it's an acute or chronic disease or a chronic disease, it's very difficult to get luminal iliac to the luminal aorta. So most of the time you get a subintimal passage of the wire which is going up, and you may not get into the true lumen. For that, a lot of devices has come to the market, and like the re-entry devices and all, but it's often challenging. So we are going to show you a case which is having aorto bi-illiac occlusion, and what is this technique that is called balloon in balloon angioplasty, which I have been doing. I have devised this technique basically at Visakhapatnam, India. This balloon in balloon angioplasty for chronic aorto bi-illiac occlusion. We are going to demonstrate that. The lesion here, aorta and the bi-illiac occlusion, and this is the kidney over here. So let's say this segment is occluded. Now, so whenever we are trying to pass the wire from this to this, we often get subintimal, and we will go in the wall and we will go up. So we will never be able to come into the luminal segment. So what we are trying to do is, once you have crossed from one side into the aorta, we put a balloon like this. We put a balloon here, and then we go with a long seat, and then we put a beveled needle through the catheter over here, and then we take a chiba and try to puncture the wire, the balloon. And once we have punctured the balloon, we put a 14 wire which goes inside and makes a coil over here, and this is the wire. So once we have done that, we take a balloon from through this 14 wire, and we get our balloon into here. So it is one balloon is there which you have punctured, and the second balloon goes inside the balloon, and now you do an angioplasty. So this is called balloon in balloon angioplasty, because there is a balloon here, and now what you have done is you have punctured this balloon and put another balloon here, and this is another balloon over here. So once you have punctured, then you can just push this balloon, the first balloon, you can push up, and then the wire get pulled up into the lumen, and then you can do your kissing balloon and the stenting. So we have seen the CT angiogram of this gentleman, and now we have put two 8F short sheath from both common femoral artery going up, and then we did an angiogram which is showing there is a chronic occlusion, and we try to cross that occlusion, and once we tried to cross that occlusion, we could manage to go across this occlusion on the right side, and then we have gone into the aorta, and then this aortogram is showing that there is an occlusion over here. The infernal aorta is occluded, and there is no flow to either of the iliacs. So that's good. We have crossed from the right iliac to the arch. Now we will try to go from the left. Now this is the left common femoral artery angiogram, which is showing there is a chronic occlusion of the common iliac and the aorta. So the challenge is to go from here and cross over here and then get inside the aorta, and so I'm trying to get inside this aorta, but every time. So I have put a balloon over here, we can see. So we're just dilating a little bit of the track, this occluded iliac and the aorta, and then I'm trying to go from the other side, and every time it is going subintimal, as we understand with significant experience of this particular disease. So we understand that it is always try to go subintimal. It's very difficult to come out. So now what I've done is that with the sheath we have proceeded with the metallic cannula, and we are trying to touch the balloon, and from all the angle, epilateral, oblique, we will have a look how this looks like, and then slowly, gently I could manipulate. And this is the ejection which is showing it is a subintimal plane, and the balloon is in the intimal plane. Balloon is in the basically a true lumen on the right side. The left side I'm trying to touch that balloon, and so it's a subintimal injection. Again, I'm trying to see from the lateral view, and I understand it's all in the, again, in the subintimal view, subintimal plane. So that's a lot of struggle and trying permutation and combination of various things, and then we decided to go for a balloon in balloon angioplasty. So I'm just trying to take a Chiba over here, and you can see that I've just punctured the balloon. Just have another look here, and this is the Chiba going in through the metallic cannula, and you just punctured it here. And once we have punctured the balloon with the Chiba, the inflated balloon is getting deflated, and with that Chiba inside the balloon, I will push my wire safely into this balloon. So this is my 14 wire. You can see that this is my 14 wire. It will go up and it will loop over here inside the balloon. That is what I desire for this special technique called balloon in balloon angioplasty. So this is the wire that's getting looped on the top of the balloon over here from the right side, and then I navigated one balloon in the over this 14 wire. So this is the right side balloon, and the left side balloon that's going over there. Then my left side balloon is sitting over the top of the right. So that's fantastic, that's safe, and that's what should be the target. So now this is the right side balloon, and this is the left side balloon. This is the wire inside the balloon, and then we just pull down and do a little bit of angioplasty, and then just to take it to the luminal plane, we just push it up, and once we push it up, we have both the balloon into the true lumen, and then it's you go across with your wire, and this is what it looks like. And once you have taken both the wires, you can do a piecing balloon angioplasty, and then of course you can put your stents, and once you have deployed your stent, so this is the stent from the right, and then this is the stent from the left, which has been deployed over here. Both the stents simultaneously getting deployed from the aorto bi-illiac. It's a double barrel over here, and then crossing the aortic bifurcation, and then coming down over here. We can see the stents are getting opened slowly, gentle opening of the stents. Yeah, you can see the stents over here, and this stents also getting open. Now the left side stent is getting open. This is the right side stent getting open and nicely positioned over the same level, and then we get going, and you keep deploying all the way down, and then of course you have a fantastic reconstruction of this aorto-iliac segment. So, and then a little bit of angioplasty here, and then finally you look at a great picture which is showing aorto bi-illiac occlusion has been recognized well with this balloon in balloon angioplasty technique. Thank you very much.